Hello, everyone, and thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Kathy Riley, the Associate Director of Programs at CSCLA, and I'm really honored to welcome you to this week's webinar on the topic At Your Cervix, How the Pap Smear Helps Prevent and Detect Cancer. And before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization that provides vital social and emotional support to families facing cancer. And that includes patients and caregivers and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs like this one. And if you would like to learn more about our services or watch past webinars, you can visit our website at cancersupportla.org. And before I introduce our speaker for today, just make a note that your video and microphone are automatically disabled for this webinar, but you may enter your questions into the Q&A feature found at the bottom of the Zoom window at any time. We welcome your questions, and questions will be answered at the end of the presentation. And we may not be able to get to all of your questions today, so thank you for your patience with that. Dr. Mona Guo is a gynecologic oncologist and assistant professor at the Keck Medicine of USC, who specializes on treating all forms of gynecologic cancer, such as ovarian, uterine, and cervical cancers. Her research interests are focused on strategies to enhance patient-provider interactions, and her award-winning research has also been widely published in peer-reviewed journals. In addition to her clinical work and research, Dr. Guo is committed to educating the next generation of gynecologic surgeons and serves as both the Assistant Fellowship Director of Gynecologic Oncology and an Assistant Professor of Clinical Obstetrics and Gynecology at the Keck Medicine of USC. It gives me great pleasure to welcome you today.
Thank you so much, Kathy. We have a small group today, so I will try to answer questions as they come up. And I do want to really highlight how wonderful the Cancer Support Community LA is. And if you haven't used their resources or haven't looked into it, please do. So we're going to be going over some basics about both cervical cancer as well as screening for it and ways to prevent it. There'll be some time for questions at the end, but like I said, if something pops up, hopefully it'll show up on my screen, but if not, I'll go over all the questions at the end as well. Starting just with the background and a little bit about our anatomies, our female anatomy. We kind of get this over the course of our schooling, maybe a little bit in middle school and high school, but I feel like a lot of people, even a lot of non-gynecologic doctors, don't quite know what's going on down there as well as we probably should. So here is a cartoon of the human body. You have up here the lungs, the chest, the breast tissue, the liver, stomach, large intestine, small intestine. Way down here is the pelvis, which contains the bladder, which sits right behind the pubic bone, that firm bone that sits right under your abdomen and above your mons. And then behind the bladder is the uterus. On the side of the uterus, you have your fallopian tubes and ovaries, and your cervix kind of scooches down right behind this bladder. Looking at this photo, which is what's out in a lot of waiting rooms and what you would see often on popular media. This is, again, that uterus, a cross-section of it, vagina leading up to the uterus, the opening of the uterus, the bottom about 4 centimeters is the cervix. That is what we can see during a speculum exam. We can't see anything else going on up top. The inside of the uterus is the endometrium. That's the lining that bleeds with periods, that responds to hormones. That's also where a fetus would grow. And then you have your fallopian tubes and ovaries on the side. Our uterus is about the size of your fist. And again, that cervix is under that, about 4 centimeters. So in postmenopausal women, the uterus is often the same size as the cervix, if not sometimes smaller. We'll be talking about this specific area here of our anatomy. So cervical cancer is still, unfortunately, common in the US. This year, about 13,000 women will be diagnosed with it, and unfortunately, just over 4,000 of patients will die. It occurs in younger women compared to a lot of our other gynecologic or female cancers, most often diagnosed in the mid to mid 40s. Precancer or dysplasia can occur a decade before actual cancer, and that's why screening is so important and so vital. It is almost always caused by the HPV or human papilloma virus, which we'll go over a little bit in the next few slides. And risks of getting cervical cancer are a few things, but mostly it's risks of having the HPV, having this virus cause more effects on your body. And so situations in which that would be the case is if you have a weakened immune system, such as having HIV, taking immunosuppression medicines because of whatever reason, such as sometimes with autoimmune disorders, history of any type of organ transplant where you have to be on certain medications, having other sexually transmitted infections, and having a higher number of sexual partners. That often happens just because you're being exposed to HPV more. And then smoking. I underline that because that's one of the few one of the only factors that we can control ourselves that would decrease your ability to get this virus, because smoking can affect the way that your body interacts with the outside organisms. So what exactly is HPV? Looking at human papilloma virus as what the acronym is, it is a virus that causes papillomas or warts. So there's over 200 types of this virus, and most of them are not ones that will cause cancer or cause a lot of human issues. HPV also can affect other mammals. But about 50 of them are considered sexually transmitted. We don't tend to consider it in the same way as chlamydia or gonorrhea or syphilis as an STD or an STI, even though it is sexually transmitted. And that's because almost all of us will end up being exposed to this virus over the course of our lifetimes. If you've had sex once or 10 times, you have the chance of being exposed to it because it lives on the outside of our bodies and is around just like the common cold. Currently, so like today, 42 million people in the US are currently infected with some type of HPV. And assuming that maybe there's 200 million adults in the US, you can see how of a significant percentage that is. And then there's 14 that are high risk. Those are the ones that end up causing cancer. Cervical cancer is just the tip of the iceberg. Cervical cancer and precancer. It also causes other cancers such as of the head and neck, so that's oropharyngeal, anus, the vulva, and the vagina, as well as penile. So and then these are the two 16, 18 that cause the majority of the cancers. So how exactly does it end up causing cancer? These viruses can linger around cells of the cervix. Any virus have specific proteins in them that make them able to disrupt the normal growth and division of cells and cause issues with them. As it affects the growth of these cells, it can cause something called dysplasia, which is also just another name for precancer or abnormalities in the cells. Not cancer yet. Dysplasia or precancerous cells have the potential to transform into cervical cancer over years. You remember from those prior slides, about 5 to 15 years on average. And the good news is when this happens, our bodies usually send up warning signals saying that there's something going on, and to try to fix it. It's also why pap smears are so crucial, because they can find these dysplastic cells, so that we can do something further. Some of you might be worried that if you were tested for HPV, if you tested positive for HPV, does that mean that this is going to happen? And that's not the case. Again, most people who end up getting HPV do not ever end up getting cancer. They might get dysplasia, they might not. Our body has great immune mechanisms to fight viruses and fight dysplasia, to be able to clear these infections and clear these abnormalities on themselves, which is why those other factors, such as having a weakened immune system or smoking, can affect how your body is able to do these things. So what are some things to look out for? Common symptoms of any cervical issue or female organ issue can be pelvic and back pain, heavy irregular bleeding, pain or bleeding with sex that's new and different, or some unusual discharge. You can also have problems with your bowel or bladder movements or leg swelling if the tumor or the cervical issues have advanced. This makes sense if you think about, again, our anatomy. So this is looking at everything in a different way. Your pubic bone would be right in this area, or right in this area above the bladder. This is the bladder connected to the kidneys. Behind the bladder, you have the uterus, and then the cervix is down here. Behind that is this is supposed to be your large intestine. So when cervical cancer grows or develops, it can push onto these other structures, so your bladder as well as your intestines, or your large bowel, colon, can also push on the muscles and the tissues around this area. Remember, our pelvises are not that big of a spot, so things that grow in there can affect the stuff around it a lot. It can also end up blocking these tubes, the ureters that connect the bladder to the kidney. When that happens, the urine can back up to the kidneys and cause this type of pain here when there's an obstruction. Any bleeding after menopause. If you've gone through menopause, it is not normal to start your period again or to have new bleeding. Even if it is just a little bit of spotting, you should see your PCP or your family medicine doctor or your gynecologist. Most of the time does not mean it's cancer or anything scary, but it should be checked out to make sure it isn't. I'm going to go over briefly because we're not going to be talking really about cervical cancer as the treatment and options for it, but just so we it's an introduction to this. But stage 1 of any cancer, if I hear cervical cancer, means that the cancer is just in the cervix. In these cases, surgery can be an option. Later stages, when it's stage 2, which means it's gone a little bit outside of the cervix to the vagina or to the tissues surrounding it. Stage 3, meaning it's gone further down to the vagina, gone maybe over to the ureters, and then stage 4, where it's spread more all over the place. These are treated through radiation and chemotherapy. Sometimes for stage 1 tumors, it might also be a combination of surgery with or without radiation and chemotherapy. And that really depends on the size of the tumor. If you remember from that previous image with how big or how small rather that area is, a big cervix tumor can't be cut out without damaging those organs that are around it. And then clinical trials, of course, are also and always something to consider. Cervical cancer was once the most common cause of death for women in the US. It's still number 3 or 4 globally. I think number 4 globally, but number 3 in low and middle income countries. In the 1980s is when we started screening for cervical cancer with the pap smear, and the incidence or us finding cervical cancer has decreased tremendously over the years because we're catching those precancers earlier. The HPV vaccine, which we'll talk about later, was introduced in the mid to late 2000s, and part of this WHO global strive to eliminate a cancer. That with this WHO initiative, hopefully by 2030, they're hoping that if we can get enough young men and young women vaccinated, if we can increase screening, that we'll be able to maybe even eliminate this cancer. And this little graph here just shows the chance or the incidence, so the prevalence of cervical cancer, or finding cervical cancer rather, at different ages, if someone wasn't vaccinated, or if they were vaccinated between 17 and 30 years old, or if they were vaccinated at less than 17. And in this group, is getting people vaccinated at younger ages can really decrease the chance of finding cancer in the future, or them developing cancer in the future. So Pap smear, what exactly is it? Taking a little bit of a step back, I just want to talk about what exactly a pelvic exam and Pap smear are and how they're done at the same time, but not always together. So a pelvic exam, also sometimes a bimanual exam, is where you're in your doctor's office or in your nurse practitioner's office, you're on the exam table, you put your legs up, and then someone uses a speculum to look inside the vagina, or takes their hands to palpate and feel the cervix as well as the uterus and possibly the ovaries. It can tell us a lot of things, such as how your cervix looks like, and if there's any tenderness, or if there's any discharge. So then the speculum exam is looking inside. By looking inside, we can see things, but we can also take samples. This is where the Pap smear is done, but it's also where a lot of other tests are done, such as testing for chlamydia, gonorrhea, testing for bacterial vaginosis or BV, testing for yeast infections, putting in an IUD. A lot of other things can happen during a speculum exam. A Pap test specifically is, and I have one of these here, your doctor needs to have certain things available when they're doing a Pap test. It's to look specifically for abnormal or cancerous cells by taking that sample from the cervix. It's usually done with a little spatula that's like this, and then a little mascara brush like this so that it can get on the inside. Some places still use this type of brush, which similarly, again, just goes in the inside of the cervix. All of these things are really soft. This is softer than a mascara brush. And while it can cause some cramping, it should not be super, super painful. And if it is, tell your provider, because something might be pinching. A lot of tissue out here can catch in the speculum. And so we do not want you to be uncomfortable during this. The Pap test can test for the HPV virus, but a pelvic exam does not mean that you get a Pap smear. If you're in an emergency room and someone does a speculum exam or a pelvic exam, they very, very rarely will be able to do a Pap smear. And most of the time, they're just sending for other tests. So when you do have a speculum or a pelvic exam, I would recommend asking and knowing what exactly they're doing, what are they testing for, and what you need to follow up on. There's been some changes about how often Pap smears are done over the past a decade or so. Current recommendations in the US are that Pap smear screening starts at the age of 21, regardless of sexual history, of when you start intercourse, regardless of other medical issues. From 21 to 29, you can either get a Pap smear by itself or an HPV test by itself, but that needs to be after the age 25. The reason that we do not test for HPV before age 25, and the reason we don't test for any Pap smears before the age of 21 is because in younger patients, the body's immune system is usually very good, and you can clear a lot of things a lot quicker. And so it would prevent us from the medical staff from doing unnecessary further tests that aren't potentially necessary. Age 30 to 65 is when this co-testing, which means doing a pap test with the smear, and testing for the HPV virus is done together every 5 years. Most people, I think, would end up doing this. You can just do HPV test alone without the pap test every 5 years, or a pap smear alone every 3 years. Some of you might have heard of HPV self-collection or self-tests that have recently gotten FDA approval. We haven't really started doing that in clinical practice in a lot of academic centers quite yet, or much in the community, but I'm sure it's going to start picking up more since it's obviously a lot easier and less traumatic for a patient to collect this themselves. You can reach a lot more people who might not be able to come in for a pap smear or might not have the time to make a 8 to 4 p.m., like 8 a.m. to 4 p.m. clinic appointment when you're at work or taking care of your kids. I guess one downside of these HPV self-collections is that you'd lose the chance for someone to actually take a look at the cervix, maybe take a look at the vagina or the vulva to be able to make sure there's nothing else that is abnormal. But there's pros and cons of every new technology. And then after age 65 or after a hysterectomy, you don't need PAPs anymore, as long as the previous 3 pap smears that you had done were normal, so that you had good screening, and there was no history of a very abnormal pap smear or a high-grade pap abnormality. Total hysterectomy means that the cervix needs to have been removed. People can get subtotal hysterectomies, which might mean that the cervix remains. They can get supracervical hysterectomies. So if you have had a hysterectomy, which have had something to take out the uterus or to take out the womb, ask your doctor to know what exactly was taken out. Certain special cases, I've alluded to this, but if you had a prior high-grade abnormal pap smear, so this is also known as CIN2 or CIN3, you do need to continue testing for 25 years. Weakened immune system or HIV would be at diagnosis or after 21. And then again, your history, family history, sexual history don't matter. All right, so what exactly do these pap tests show? Most common is normal. So NIL or NILM just means negative for any lesion, negative for malignancy. It can be something called ASK-US, which is atypical cells, unknown significance. Can be high-grade or low-grade abnormal cells, so low-grade intraepithelial lesion or low-grade lesion or high-grade lesion. Can also have something called ASK-H, which is atypical cells, but seems like they're more high-grade. Atypical glandular cells, and then when you just test for HPV, they will say high-risk HPV present or absent. And the high-risk ones that they test for are these ones specifically. Remember, 16 and 18 are the ones that cause about 70% of cervical and other HPV-related cancers. So we're going to look at these situations here first, but ASK-US. This can happen just with like when your vagina is really dry, if you've recently had sex, if you have an infection. Those things can all change the way that the cells look and can look abnormal, but not be something that's precancerous. So certain times with pap smears, if it looks like it's atypical but uncertain, you might need to repeat a pap smear or repeat it in a couple of months. For these ones here, just going over what this means, these are cells from normal to cancer. Cancer means that the cells are growing so much that they're kind of breaking through the barriers, the normal barriers. In between here is the dysplasia, or the abnormalities and precancer cells. If you're looking here, everything is very layered and ordered. So as the cells become less layered, less ordered, and the nuclei, which are these black beans, are getting bigger, that's when the cells are getting more abnormal. These are also similar names or different ways of saying it. When you have low-grade abnormalities, it can be SYN1. When you have high-grade abnormalities, it can be SYN2 to 3. Importantly here, you see that the arrows go backwards. We can move between these abnormal cells and normal cells throughout our lives, really. Once you move to cervical cancer, you can't really come back to any of the previous ones unless you get your cancer treated. So again, if your pap is not normal, it can just mean nothing. It could be things that happen like infections, hormonal changes, intercourse, using a certain douching product. So before getting a pap smear, just avoid putting anything inside the vagina, or delaying your pap smear if you do feel like you have an infection, if you're on your period, or if you recently had sex. It can mean just closer monitoring, that you have a pap smear that shows something abnormal, but they'll just repeat it in 6 months or 1 year instead of the 3 years or the 5 years. It can be a colposcopy. Colposcopy is just a fancy way of saying it's looking at under a microscope. The doctor will look at your cervix with the speculum, put some vinegar on it to find these abnormal cells, and then potentially take some biopsies. Can also do immediate treatment. If there are cells that look very abnormal, there's procedures that the physician or the provider can do to remove those abnormal areas of the cervix, assuming that it's precancer again and not cancer. So for these two, this is usually what can be what a colposcope looks like. Again, it's a microscope. They look in through a lens that is outside of the vagina that focuses into the cervix. And this is what we see on the inside. It can look like normal tissue, or it can look abnormal. The treatments can be taking it off, so excising using a knife or using a LEEP, which is the electric loop, to take off a portion of the cervix. Some places still do laser of the cervix, or cold therapy, cryotherapy, though this is less frequently done nowadays. And now for the HPV vaccine. So any vaccines, the way that they work is that it teaches the immune system to recognize a virus and then to create some antibodies to fight the virus. So the vaccine will give you something that looks like HPV, but it's not HPV. And then your body will see it and develop these antibodies to fight it if they ever see it again. Which is why a vaccine is recommended before there's actually any exposure to the actual virus. Because if you get an infection and you don't have already these antibodies around, then this infection can start infecting. Or if you get the virus and there's no antibodies around, these viruses can start infecting and causing those abnormalities in the cells. So then once you have these antibodies, once you have these soldiers of the immune system that are specifically for the human papillomavirus, if you're exposed to the actual virus in the future, these antibodies can now come and clean up and take care of those viruses before they cause any issue. And this is how the HPV vaccine works. It's also how most other vaccines also work, more or less. There are different versions of this vaccine in different countries. In the US here, Gardasil 9 is now the one that's most commonly used. Back before 2014, it was Gardasil 4. So afterwards, it was upgraded to 9, which means that it covers 7 high-risk HPV viruses and then 2 low-risk ones. And 16 and 18 are those 2 baddies, the ones that cause 70% of the cancers. Just this vaccine will be able to prevent more than 90% of any HPV-related cancers. So again, that's cervix, but also vagina, vulva, penis, head and neck, or the oropharynx. In Australia, they did a pretty big study of vaccinating 8,000 girls with either the vaccine or the placebo. And 4 years later, 2 of the 8,000 girls had HPV infections, whereas 100 of the 8,000 girls had HPV infections. Also, the incidence of genital warts also went down in men who weren't vaccinated, again, just by decreasing the viruses that are getting transmitted between people. We do recommend, currently, still recommend in the US to vaccinate everyone between ages 9 and 26. So boys and girls, men and women. Ideally, earlier age, because earlier vaccination is more effective before there's been any exposure to this virus. It is, because it's recommended, it is covered by, should be covered by all insurances, and covered by a lot of the childhood, more global childhood coverage programs. So even if there's no insurance, it will still be covered for children. It is FDA approved in the past few years to be given up to the age of 46, so 45 and below. This is for men and for women, and it can be helpful even if you've been exposed to HPV before, because it can protect you from the other types of viruses, not the ones that you didn't get, and maybe stimulate your immune system to help fight the virus that you do have. So ask your doctor, your gynecologist, PCP, or family medicine person about the vaccine if you haven't gotten it before. It's a series of 3 vaccines once now, but if you do get it when you're before 14 or 15, it's just 2 shots instead of 3. So how can we prevent it? The main thing is vaccinate. That's the best way to prevent cervical cancer. It's one of the few cancers that we can actually prevent. And we have a vaccine for it, which is pretty amazing. Get regular pap smears and then tell your family and friends to vaccinate and get their pap smears. If you can't prevent you from getting the virus, then we should catch the infection or catch those abnormal cells earlier so that we can do something about it and prevent things from getting towards becoming abnormal to the point of cancer. And then stop smoking if you are smoking, specifically for cervical cancer, but also for other health reasons. Like one of the preventable, modifiable behaviors that we can do. So 95 to up to 99% of cervical cancer is preventable with screening and HPV vaccine. So we can make that WHO goal of eliminating a cancer if we can get enough of these public health mechanisms out to patients. And then I wanted to just end with a little bit with some common misconceptions that I hear from my patients or I hear being talked about out in community. Some of them I've gone over before, such as pelvic exams and STI testing does not equal. So this is a misconception that just getting a pelvic exam or getting screening means that you've gotten screening for cervical cancer. I often hear people saying that, yes, I went to my gyno last year, and so I've been getting yearly pap smears, so I'm up to date. And yes, that could be true. Some places still do annual pap smears or yearly pap smears, but most of the time that's not the case. You're getting an exam. Planned Parenthoods often do not do pap smears unless you specifically ask for it. So some places can't even do it. but because they would then have to figure out how to follow up. So most of the time when you're at Planned Parenthood, they would do your STI screening or do an exam for other things, but might not be doing a pap smear. Another misconception is that having this virus, having HPV, means that you're going to get cervical cancer. Again, not the case. We can get rid of this virus. We can, our bodies can do it, or you can get medical help to do it as well. Misconception that this cancer only affects those who are older. We have, unfortunately, patients in their 20s who have cervical cancer. So it's definitely not a disease of older women. Unfortunately, it does often hit those who are premenopausal. The HPV virus actually does not tend to infect as much in postmenopausal cervixes or postmenopausal vaginas or new HPV infections. So it is really a cancer of the young. Another misconception is that if you do get cervical cancer, you can't have any more children. In the past 5 years, there's been really, really strong studies and recent practice changes of smaller surgeries or less invasive surgeries where the womb or the uterus can remain, even if you have cervical cancer, and ways to just take out the areas of the cervix have been found to be as safe as doing the full big surgery or full big chemotherapy and radiation if the tumor is small enough. So even getting cancer, as long as it's small enough and hasn't spread, you can just get that taken out and then have children and be able to get pregnant afterwards. On the flip side of that, surgery is not always the best treatment. When the tumor is too big or if it has spread, surgery would be doing more harm because the surgery can't take out everything. So doing radiation and chemotherapy would be the best way to cure someone of that disease. Misconception of this is genetic. There's are very rare cervical cancer types that are genetically passed down or hereditary. The vast majority of cervical cancer, so more than 90% of cervical cancer, is not. Most of the cervical cancer that you see that is, or any that is HPV related, this virus related, is from the virus. It's not from your genes, and you can't pass it down to your children or get it from your parents. Another misconception is that if you're not having sex, you can't get cancer. If you've ever had sex, had sexual activity, you could have been exposed to the virus. The virus sometimes just sleeps or hides inside the cells and takes time to reemerge. And so that's why pap smears are still so important to be able to catch that reemergence if it happens. And then similarly, if you got the HPV vaccine, you do still need pap smears. Getting the vaccine doesn't protect you from all of the 50 high-risk viruses, protects from the 7 most high risk and 2 of the low risks, but there's still a lot of other viruses that are out there. And so you should be doing the screening. This is a great resource, Foundation for Women's Cancer. It's part of our society or branch of Society of Gynecologic Oncology. And it has a lot of really good patient information. You can also search for locations around you by putting in your zip code for where you can get pap smears. This one right there, that's where Cancer Support Community LA is. And that's it. So thank you so much for having me. I'm happy to answer any questions. My email is there if you have any questions that you want to ask about. And I think Kathy will mention this later, but if you do want the slides, just reach out to Cancer Support Community and they'll be able to get them to you. All right, let me see. I don't think I see any questions though. Oh, no, there is Q&A. Oh, I opened the wrong chat. Okay. So there are a few questions here. Let me go over them. So the first person asked if breast cancer at any stage possibly leads to cervical cancer. Breast cancer usually does not. Breast cancer and cervical cancer usually are not linked together, not in the same way that breast cancer and ovary cancer or breast cancer and uterus cancer, those can be linked. So cervical cancer, because it's due to this virus, HPV virus, that's the cause of it. And HPV virus, that virus does not cause breast cancer. So there's not really a percentage for it. The caveat there being is that people with any type of cancer, you do tend to be probably more immunosuppressed, and then some, because of that or because of going through cancer treatment, you're not getting routine exams or routine screening for all of the other organs. And so it might seem that way, but it's not directly linked. Someone asked if the cervix remains when a hysterectomy is performed. Depends on the type of hysterectomy. So total hysterectomy, if the word total is in there, then the cervix should be removed. But the uterus can be removed by itself. The uterus and the fallopian tubes can be removed, but the cervix remains. The uterus and the ovaries can, and the fallopian tubes and the ovaries can be removed, and the cervix remains, or any combination. But cervix can stay back when you have a hysterectomy. And then after having cancer, should you get a pelvic exam more often than 3 years? Yes, if you have had cervical cancer or even cervical dysplasia, so the cervical precancer, you should be getting pelvic exams or and probably pap smears more often. So depending on what treatment, what type of abnormalities there were, it will be different for how often it can happen. In the beginning, so say just for cervical cancer, if you were treated for cervical cancer, you would be getting exams every 3 months, probably for the first 2 to 3 years, and then spacing that out to every 6 months to annually or yearly. Someone with cancer, with a history of cervical cancer, will get probably annual or yearly exams for the rest of their life. If it was a precancer, then in the beginning, you might be getting sooner exams, so at 6 months and then at 1 year, and then maybe yearly for 3 years after that, and then you might space out to every 3 years afterwards. So it depends on what exactly you were treated for. Lichen sclerosis, that's a great question. So the vulvar cancer is related to HPV. HPV can cause vulvar cancer, specifically HPV-related vulvar cancer. Lichen sclerosis is it's an immune process that causes changes to the outside of the vulva. It happens most often in postmenopausal women, those who are older. So in 60s, 70s, is more happens most commonly. Itchiness, sometimes pain, but most often it's itchiness. And it can cause some changes in how the outside of the vulva looks, where like the labia just are a little flattened. Sometimes because of all the scratching, it can lead to fissures or tears. That type of the condition is not usually related to HPV, and it's an autoimmune issue. And so it can also lead to cancer. So if you have lichen sclerosis, you do need to get routine checkups as well and use steroid creams to treat it, but it's not HPV related. HPV positive for more than 2 years, yes, it can happen. Unfortunately, we have some people that are just HPV positive continuously because of whatever reason. It's hard for their body to get rid of the virus. When you have persistent or continuous positive HPV that is just there, but the cells look normal. So HPV positive with the pap smear is normal. You could kind of go down different ways depending on your discussion with your doctor. You could get a colposcopy, so that's taking a look with the microscope to see if there's anything that looks abnormal, to do a biopsy. And then if there are cells that look abnormal, you might need to do repeat excisions or repeat treatments. There's one small study that came out 3 or 4 years ago that looked at a specific supplement called AHCC that is a mushroom supplement. I think it's a mushroom from Japan, but you can find it in like any of the supplement stores. That taking a daily supplement of HCC was shown in a small study to decrease HPV in like 50 to 60% of women. And it's one of the few supplements that has like research behind it showing that it can help clear HPV. So I guess that was a really long answer to this question. So it's not normal in that you can just ignore it, but it is, we do see it, unfortunately, a lot. And then hysterectomy because of endometrial cancer, it depends on what stage that endometrial cancer was for how often you have to get pelvic exams afterwards. Usually, if it was an early stage, something that's stage 1, probably you'll get it every 6 months for the first few years, and then it'll become yearly. Most people will still do yearly exams afterwards. If it was a higher stage, it would be more suited, it would be closer, it would be more frequent than that, like every 3 months. Endometrial cancers, as long as you do not have a history of cervical issues, you do not need to keep on getting pap smears with endometrial cancer though, because your uterus is out and that pap smear looks for cervical cells and it's good for cervical cancer screening, but the pap smear will not be giving you information about endometrial cancer. And I'm happy to talk about other women's cancers as well in the future. So thank you guys all for coming and for engaging and asking questions. I hope this was helpful.
Well, thank you so much. I know you've presented for us before, and I always learn so much every time. So we hope to have you back and focus on other women's cancers in the future. So we thank you so much for being a part of this webinar today and for sharing your expertise with us and answering all of the questions that came up. And someone is asking, I just saw something else pop into the Q&A. Will we get a recording? The webinar is being recorded. It will take just a little bit of time for us to edit it, and then we will upload it to our YouTube channel, and it'll be in our video library at CSCLA. If you want to know where those links are, you can email us at info@cancersupportla.org. And Abby, maybe you can put up our last slide and it'll have that email and our website on this. Wonderful. Thank you so much. So if you would like a copy of today's slides, or you have questions about where to find the recording once it's posted, please email us at info@cancersupportla.org. And if you want to learn about any of the other programming that we offer, just visit our website at cancersupportla.org. We have a wide range of support groups, including support groups, post-treatment women's health support group that you're welcome to be a part of should that describe you and your current situation. There's a QR code here that will help you in getting started. We hope to see all of you at a future webinar. And again, thank you so much today, Dr. Guo, for joining us. We really appreciate it. And thank you to all of our attendees. And we will see you at a future webinar. Take care, everyone. Goodbye.
Bye-bye.